For those of you who don't know me, I'm Mike Parkinson. I, along with my colleague Yoram Vodovotz, were your co-chairs, and we want to welcome you to Pittsburgh. Many of you had a very difficult time getting here. Some of our colleagues are still en route, particularly if they're up in the New England area, but they're striving to make this meeting, and we're complimented by it. We're very, very honored that you all took the time out of your busy schedules, whether you're here at the University of Pittsburgh or UPMC, or really from coast to coast. So thank you so much. I want to turn it over to Ron Stout. We are very gracious to the Ardmore Institute for their sponsorship and partnership with us here at the University of Pittsburgh for what we think is a unique summit of some of the thought leaders in the country in this room to help us define a research agenda to energize the broadening area of lifestyle medicine, its major domains. And so, Ron, I've turned over to you for a couple of welcoming comments, but thank you so much deeply from our heart for your leadership and that of the board of Ardmore. Several of their board members are here today as well.
Well, thank you, Mike, and all of you. I wanted to say thank you to UPMC, to University of Pittsburgh, and to Mike and his associates. But I'd be lying to you if I didn't tell you I was a little bit nervous being up here. And it's not only because of all the luminaries in the room, it's more to the fact that Mike is a storyteller. And I've worked for Mike and with Mike for 30 years, and he can tell some stories. So, thank you all. Thanks again to each of you for being here as we look at lifestyle medicine research and look at the gaps in the evidence base and how to move forward. The Ardmore Institute of Health is an organization that envisions a time when lifestyle and lifestyle medicine will be the preferred choices of treating, preventing, and reversing chronic diseases. We really believe that as individuals and organizations, we need to partner together to make lifestyle medicine foundational to the healthcare system here in the United States. We really believe that lifestyle medicine will not have accomplished what it could and should until it's democratized, until it really reaches the socio-demographic arena that needs it most and that probably will have the hardest time getting it. And we really look to partner with folks to make the healthy choice, in fact, the easy choice, the preferred choice, the cheap choice, the logical choice. And I think that is something that's going to have medical and environment and other things married together. So once again, thank you for being here. I would be remiss, though, if I didn't recognize a couple of people. One, Janet Calhoun. Janet, if you can wave. Janet is our Chief Operating Officer and Senior Vice President, and she's been on our board for 10 years and recently came on to help us take this to the next level as we partner and collaborate with all of you. And then I lastly want to recognize Franklin House. Franklin, in many ways, is the grandfather of the organized lifestyle medicine approach. He is our former CEO, president, chairman, currently serves on our board, and is just an all-around good guy. So with that, thank you all very much, and we look forward to a day and a half of learning.
The word that Ron used a couple times there was choice, preferred choice, logical choice, cost-effective choice. And we're also delighted that in addition to the 6 domains that we're going to be talking about this morning, that we have national experts on the built environment and on our ecosystem and on the pressing changes of global climate change, which are increasingly a physician issue. Dick Jackson, I see others in the audience. So we're going to have quite a ride. By deliberate, this was an invitation-only meeting. We know that you all have expertise, and we're challenging each other here to look across our silos and our traditional ways of organizing medical care and our thinking to look for breakthroughs. So think of breakthroughs, the aha moments that you hear from somebody that you don't normally hear from, somebody in a hallway conversation or a cup of coffee, you might have learned something. Jot it down, let us know how you do that. Ron used the term lifestyle medicine. Let's level set, okay? So lifestyle medicine, whole food, plant predominant dietary lifestyle, physical activity as a regular part of daily living, restorative sleep, stress management, avoidance of risky substances, tobacco, alcohol, opioids, addictions of all types, and positive social connection as a primary therapeutic modality for the treatment and reversal of chronic disease. The time has come. the science has emerged from the mitochondrial level. Dr. Bernard is going to be talking to us in a minute. He uses the word mitochondria when he actually speaks on public TV stations to the lay public about a mitochondria. Amazing. Every time he says that, it's like, I can't believe you were doing that. But that's the level of engagement with the lay audience that we have possible today. So Yoram and I sat down and said, where are we going on this journey? Begin with the end in mind. So the product is to define research priorities in the core areas of those 6 domains. What are the existing knowledge that we have, and what are key gaps related to the behaviors and environment for the leading causes of death, disability, and disease? The emphasis on clinical treatment at this meeting and reversal. What do we know works? What do we don't know exactly works and why? And what can we do to accelerate that? New insights, breakthroughs, or collaborations in siloed practices, populations, or methods. There's been an explosion of new research methods. Yoram is probably one of the leaders in the country in silico modeling. Artificial intelligence. We'll have people from Google here, people from the military. Why aren't we not applying these technologies and research methods to patient populations and long cohort studies and sera banks and things that we have access to? Big challenging questions. All of the things you see listed here, lifestyle-induced associated inflammation, immune dysfunction, dysbiosis, microbiome alterations, epigenetics, proteomics, these are all words that when I was in medical school didn't even exist. These are new scientific tools that were just being leveraged, oftentimes not in mainstream but peripheral ways. Those new research methods and new definition of populations. Populations that we have underserved and understudied need to be brought to the fore. I told several people here, 4 NIH center directors wanted to come to this meeting, asking about the timing of these types of topics. This is something they were looking at, and they wanted to be able to attend this meeting. So I think the timing is right for that summary white paper to hit. Now, when Yoram and I sat down, he with his clinical basic science in the Department of Surgery here at Pitt UPMC, and I sat down over a cup of coffee, we came up with this on a cocktail napkin. Essentially, the emerging sciences on that y-axis, epigenetics, biology, physiology, neuroplasticity, clinical outcomes, by the domain on the x-axis, the 6 major domains, and the new research methodologies of analysis on the z-axis, if you will, that 3-dimensional diagram creates opportunity, cross-sectoral ways for us to brainstorm to create breakthrough research opportunities for funding agencies, both federal, foundations, private, who are looking for a roadmap agenda. So keep this visual in your mind, this 3-sector collaboration between emerging basic science and sciences we understand at deep cellular levels, lifestyle medicine domains that people have been lecturing people about for years but don't seem to change much, and new research methodologies that we have available. Our journey is going to be in 2 phases. Today is a deep dive into each of those 6 major domains with a foundational review by an expert in that domain saying, what do we currently know, and what, in his or her expert opinion, are the primary research priorities for the next 3 to 5 years. That will level set for the panel discussion. Many of you will then be serving on panels to make a brief 5-minute, 3 to 5 minute reaction commentary, with or without a slide, to what that foundational speaker said in those 6 domains, and then we open it up for everybody to talk and discuss what's going on. The final session will be on the built environment, choice architecture, and exposures. Chemical exposures, environmental exposures. We've got one of the pediatric experts, Dr. Leonardo Tresande from NYU is here, and we're going to be talking about what often gets forgotten in lifestyle. It's the architecture of choices. It's the built environment. It's the natural environment, or the lack of, and things like global climate change. A lot to cover, but it's the integration of those where value lives. Day 2 is going to be the cross-cutters, which I look at what are the barriers and opportunities in the way we organize research that have now perhaps been open to us. So what are the core new sciences and common pathways that cut across all 6 domains? What do we know about integrative medicine and clinical research in terms of how those are being combined, or things we can do? Kids, African Americans, women, populations at high risk that have never been studied at all. I'll give you some data here in a minute. What are current research methods, including folks, we've got Paul Verschoor came in from Barcelona, some of the amazing research they're doing in collaboration with Yoram and other researchers around the world in this. What are federal and foundation perspectives? What are people thinking? What is the National Institute on Aging thinking? Again, personal view. What is the American Heart Association up to? Dr. Sanchez is here, who's their chief medical officer for AHA, huge funder of research in our country. What are other foundations that we should be impacting through what we learn over the next 2 days? And then we'll talk about the opportunities for you to engage as either an author or a contributor with a potential honorarium as associated for the writing of that white paper, which is what we want the Magna Carta essentially to produce, so that 10 years from now, all of you in this room will say, I had something to do with that paper that drove the changes that we saw, that led to accelerated research and practice in lifestyle medicine. So in the past year, and literally in the past 60 days, there have been 2 major national papers that have been published that are absolutely relevant and timely for us to think of. The first one was authored by Steve Wolf, who was here today with us, which is just phenomenal. Steve, when this paper hit last week in JAMA, that basically was a 60-year review of mortality in the United States, but it was special focus on what's happened over the last 20 or so years. It was the light bulb that went out for me, because while I've heard about this, I had not seen it. So essentially, for the United States, which for decades saw a decline in mortality rates, the mortality rates are now rising after decades of decline. The life expectancy for the average American plateaued nearly a decade ago in 2011. And the most significant decline is happening most in people in the productive years, in the Middle Ages. In those ages, and you can see here for the age groups, essentially down in the lower left to you, 25 to 44, the dip as it relates to age-adjusted mortality, right? It's just going in all the wrong directions. And when you look at it by cause, it's not some bizarre infectious disease. It is drug and alcohol use, suicides, hypertensive diseases, all as a reflection of lifestyle, diabetes, and obesity. These are the core causes for the decline in U.S. life expectancy in our most productive years. So it's really timely and urgent for us to be able to look at this. A week before that, there was an analysis of the NIH Prevention Research Portfolio that looked at all NIH-funded research for the period 2012 to 2017. Using the most generous definition possible, only 17% of total NIH dollars were put towards anything that might be called primary or secondary prevention. But when the researchers drilled down further to say for those 11,000 projects that they identified, only 26% addressed the leading cause of death as the outcome. Death is an important outcome, but they weren't looking at death as the outcome. They weren't looking at heart disease, cancer, accident. 26% of the time they looked at those. That means 74% of the time they were looking at the leading cause of death. 34% of that 17% addressed one of the leading risk factors for the death, which is diet, tobacco, blood pressure, weight, elevated blood sugar, high cholesterol. A third addressed the leading cause of disability. So what it tells you is for disease, disability, or death, that 70% on average of NIH research is not going to the things that caused the mortality declines that we saw in the previous analysis by Dr. Wolf and his team. And when they looked furthermore at the gold standard, and we'll talk more about, is the gold standard of RCT a gold standard anymore? Or new research methods can basically leapfrog the RCT, but they looked and said of all that money, little money that was spent in prevention research, only 25% involved RCTs. And when they looked at multiple causes of death, meaning a person who has 2 risk factors, which is what we know from our clinical practice, how most patients present, only 3% of the studies actually were real life enough to say that the person's overweight and they've got diabetes, or they're overweight and they smoke, or they're overweight and they're stressed, right? So the opportunity for this white paper to land in this milieu of declining mortality or increasing mortality, and for the causes that are unlinked to the real world, I think is very timely indeed. For the populations that they looked at, 20% or less of the dollars spent in this prevention bucket were for youth, 10% or less were on older people, urban populations, or women, or particularly pregnant women. 5% or less of the research were in populations of low income, rural, sexual minorities, institutionalized, or the disabled population. So the very populations that may be challenged the most are seeing the least amount of research emphasis. Those studies are largely observational. 25% were RCT. Some are just looking at existing data sets. How should this change going forward from this august group of people that we've assembled here today? Ron talked about reversing existing disease. So the money went to preventing new disease or slowing the progression. Some of it went just to methods, some of it went to screening, and some of it went for screening for a risk factor. But you don't see an aggressive reversal agenda for lifestyle to reverse disease as a part of the research priority of the NIH. It's just not on the radar screen. These 6 domains comprise Steve Wolf's work long before the paper he just published, 90% of preventable disease, disability, and death. And yet the research portfolio does not address them, my personal view. And we have an urgent platform now to act on them. The third article that I asked you to peruse was 25 physicians a year ago published the impact of lifestyle medicine if it was broadly applied. Dr. Michael Grieger, some of you know, many authors, Dr. Bodai in California, 25 physicians of multiple specialties, they put a marker on the ground and they said, it's all inflammation. I'm simplifying here a bit, but figure 1 in that paper, and this is where I came to Yoram, and I said, Yoram, it's the same chart that you do for trauma-induced inflammation research with the DoD. Unhealthy diet, sedentary lifestyle, high stress, medications, many of the medications that we use to treat these conditions actually boomerang back and cause some of the adverse consequences that we're trying to prevent. I added sleep, addictions, and social isolation, but the common pathway is dysbiosis, oxidative stress, cell injury leading to chronic sustained inflammation, which is an early precursor for heart disease, diabetes, 91% type 2 diabetes, and depression, and a whole host of inflammatory disorders, autoimmune disorders, rheumatologic disorders. It's the same pathway. The science of epigenetics changes everything. The rapid expression by our genes of proteins within minutes or hours or days of what we eat and how we move and how we positively think or not. It's dramatic. Joe Maroon, who's a neurosurgeon, can't be here today. He got pulled away. 2 of his neurosurgical residents hopefully are going to come. I don't see them yet. But he basically said, Mike, it's all about neuroplasticity. When you talk about how the brain cures itself or doesn't cure itself, and it lives in things like epigenetics and what's happening at the cellular and subcellular level, like Neil talks about in mitochondria. This happens frequently, and it's underappreciated by doctors and by researchers. I think it's a powerful slide. Yoram's application of this is huge in my thinking, and I want him to give you a quick snapshot. He'll be on multiple panels over the day as we go forward.
Thanks, Mike. I also just want to give my own thanks to everyone for persevering through weather and other issues to get here, and we really appreciate your being here. So inflammation is complex. So I think that one of the reasons that there has not been the type of progress that there could be in this field, where there has been already an appreciation of the word, the role of inflammation, is that I think there has been a gross oversimplification of what it means to be inflamed. Number one, first of all, it's a focus on very limited markers. Many of those markers are very non-specific. They are fairly divorced from the mechanism that makes them happen. So inflammation, as complex as this diagram looks, is more complex than this. However, as spaghetti, looking as these diagrams are, they're actually not that complicated. And I highlighted in red what I consider to be the core sort of main engine of inflammation, which is this, to simplify it, it's what I call the inflammation to damage or dysfunction to inflammation positive feedback loop. So you could start with damage or dysfunction, which drives inflammation, which then makes more damage and dysfunction, or you might start with inflammation, which damages or causes cells to become dysfunctional, and then that causes secondary inflammation. We now know a lot about the molecular mechanisms that make this happen. Inflammation, while it's bad, is also the primary means by which your body communicates to itself that anything is actually changing. Stress is really just a way Mother Nature of letting you know that you're either doing something wrong, you're in the wrong place, or something's injured you or infected you, and you need inflammation in order to resolve that, in order to heal that. So therefore, it's evolutionarily conserved, and it's completely necessary for everything that we do, and that's what makes it so paradoxical, because how does it get out of control? Well, the same mechanisms that allow you to ramp up rapidly a response to a real problem, like an injury or an infection, right, these positive feedback loops, are the same ones that in a state where you have certain lifestyle factors or environmental factors that exacerbate inflammation, maybe with a genetic or epigenetic predisposition, now these positive feedback loops can begin to spin up and out of control, and they become the driver of the process instead of just the outcome. And the point is that we've made computational models of this. And not only that, but we've thought of them as a way to really unify this currently very fragmented process by which we try to come up with any solution clinically to anything, going from preclinical to long-term outcome. Our concept is that you could use computational models of inflammation as a binding mechanism across diseases to simulate mechanisms at the cellular and tissue level and whole organism level, which allows you to develop biomarkers and drugs. These same exact modeling tools allow us to do what Mike alluded to as simulated clinical trials. We'll have experts in that tomorrow. Steve Chang from Immunetrics, which is probably the world's leader biosimulation company based here in Pittsburgh. You can then take these models and calibrate them to data in individuals. And in fact, you could argue that you could be making an individual-specific mathematical model of you or a digital twin probably from the day after you're born, if there was the right type of data. And then you could follow it over time. So we're going to cover the role of aging as well. We have Torrin Finkel, who runs the University of Pittsburgh's Aging Institute here as well, to provide some insights. But what I've shown here with these arrows is that we use basically a single mathematical model that allows you to develop the drugs or the lifestyle modifications, to test them or predict what the test is going to look like in a clinical trial, to predict what the responses of individuals are going to be, not just now, but later in time. And so this whole process is then fed by an ongoing iterative cycle of collecting data, and we're going to have several speakers that are experts in big data at the meeting, and they're going to talk about methodologies and approaches and how those might fit into the lifestyle medicine issue. The important thing is, again, just as another graphic to recap the first graphic that Mike showed, this is kind of gives you a single picture sense of the cross-cutting nature of the meeting. We have the lifestyle medicine domains at the bottom, and then you can see the biological or physiological mechanisms that we think cross-cut across these processes, and then overlaying on that the analysis methodologies. Now again, we're obviously not going to be able to do an incredibly deep dive on every aspect of the biology or the analysis methods, but hopefully it will allow those of you that are not familiar with those processes to learn about that, and hopefully teach us about what the lifestyle medicine needs actually are.
So this is why I got so excited over that napkin right up the street from here, and why I stole some of Yoram's and Tim Billier's hard work here. He's the chairman of surgery. Some of the work done in DOD, and said, what if we applied this to the things that cause 90% of disease, disability, and death in a way that allows a research portfolio to grow and expand and be tweaked over time to inform funding agencies and our colleagues in academia and schools of public health and schools of medicine in undergraduate education. Could be very, very impactful, because these silos, once cross-cut, could be of great value. And here's the challenge. 2 years ago, Dr. Regina Toto, who was then the chief resident at Children's Hospital, one of the top children's hospitals in the country, right up the street here in Pittsburgh, and I presented what we called pediatric lifestyle medicine and environmental health grand rounds. And as with every grand rounds, we start with a case. And Regina got up and talked about the heartbreaking but all too common kid that she had seen in clinic a week before, who's 10-year-old, obese, asthmatic, bipolar, ADHD, on multiple medications, Every single day they see this patient and try in a 15-minute visit to make a difference. I highlighted here, you can read, I won't read there, but everything that she provided, I highlighted together with her in red, how many of them dealt with lifestyle and environment that we believe are impactable, but not with the current toolkits that even the best pediatrician at Children's Hospital has. This need is urgent as childhood mortality. I predict we're going to have a heart attack at a high school graduation somewhere in West Virginia very soon. I spend a lot of time down there. And it won't be in the audience of a parent. It'll be on the stage of a graduating student. Heart disease doesn't care about your chronological age. It's just time and disease. And so this is sobering for all of us, and rapid cycle research that helps these people in a way that we just can't help them today is why we're here. I'm a big believer in visuals and icons and simplify, simplify, simplify. If you have to boil it down, 2 years of Robert Wood Johnson, Mark McClellan led What Predicts How Well and How Long Americans Live. It's what I eat, it's how I move, it's what I think. And if we can get those right, whole food, plant-based eating, regular physical activity, think in quotes meaning what's my purpose, what's my passion, what's my connection to people. I see Dr. Barry Curzon here, who is a dear friend now. He's the Dalai Lama's physician, a research physician at the University of Washington who met the Dalai Lama. His background's in family medicine, Barry. But purpose is powerful and it's anti-inflammatory. That's the secret, but we're not linking them yet. And then the domains, whether you're in the home, you're in the school, you're on the work site, or it's your block, it's your neighborhood. That's why I'm so thankful to Phipps Conservatory. The event tonight, please don't miss it. It's going to be very special. The leadership that they've done globally in the area of healthy environments, use of the outdoors for therapies is critical. So that's what we're all about, to bring them together. So get ready to strap it on. We're getting ready to go here. We're going to keep people to the times. Presenters for the 6th Foundational, we want to see you 25 minutes, right? Everybody knows a lot of stuff. We don't go back over stuff we know. And then the reactors on the panels, we want you a good 5 minutes, just your reaction, just be honest. You don't have to worry about taking notes. We're recording the whole thing so we can write it all up. Snacks and beverages available in the back of the room. 5 o'clock, we'll have 2 shuttles right downstairs. Very easy, grab your stuff, go downstairs, get on the bus, and we'll be at Phipps. The reception, the tour, we're going to the teaching kitchen. The beautiful holiday decorations starts at about 5:30. We're going to have a presentation this evening by David Katz. David, thank you for making the trip. And we're going to have a reactor by Frank Hu from Harvard, who's on his way. He's struggling to get here. He wasn't as lucky as you were, Eddie, but he's going to be here to react along with Steve Wolf to David's presentation this evening. We have over here Nate and Dan at the breaks. We're going to ask you to do expert on the street interviews. 5 minutes, we got some softball questions. What would you like to tell the world in your area or outside your area that we need to think about, right? We want to be able to post a composite video with key leaders speaking either at the Pitt website and or the Ardmore website. I'd be able to do that. Please take it. Why is this important? Why are you here? What are the things we've missed? What are the things you want people to know? And then finally, network across people you don't know. I can guarantee you, Yoram and I are blessed to know most of the people. I don't know a lot of the people he knows. He doesn't know a lot of people I know. And that's why you're here, is to meet the people outside of our traditional silos. Just have fun, okay? If it ain't fun, it ain't worth doing. And I think Barry would agree with that. So with that, let's start with our first domain. Neil, we'll have you on, Neil Bernard. And we are delighted, as always, to welcome Neil to cold and snowy Pittsburgh. Right.